This is Chapter 16 of the Maternal Newborn ATI, Complications Related to the Labor Process. Complications occurring during the labor process are emergent and require immediate intervention in order to improve maternal fetal outcomes. This chapter explores prolapsed umbilical cord, meconium-stained amniotic fluid, fetal distress, dystocia, which is dysfunctional labor, precipitous labor, uterine rupture, and anaphylactoid syndrome of pregnancy, or amniotic fluid embolism. Prolapsed umbilical cord occurs when the umbilical cord is displaced, preceding the presenting part of the fetus or protruding through the cervix. This results in cord compression and comprised fetal circulation. Risk factors are rupture of amniotic membranes, abnormal fetal presentation, which is any presentation other than the vertex occiput as presenting part. Transverse lie, this is presenting not engaged, which leaves room for the cord to descend. Small for gestational age fetus, unusually long umbilical cord, multifetal pregnancy, unengaged presenting part, and hydraminose or polyhydraminose. Physical assessment findings: visualization or palpation of the umbilical cord protruding from the introitus. FHR monitoring shows variable or prolonged deceleration and excessive fetal activity followed by cessation of movement suggested of severe fetal hypoxia. Call for assistance immediately. Do not leave the client. Notify the provider. Apply a warm, sterile, saline-soaked towel to the visible cord to prevent drying and to maintain blood flow. Reposition the client in a knee, chest, Trendelenburg, or modified lateral semi-prone recumbent position with a rolled towel under the client's right or left hip to relieve pressure on the cord. Using a sterile gloved hand, insert 2 fingers into the vagina and apply finger pressure on either side of the cord to the fetal presenting part to elevate it off the cord. Stay in this position until the birth of the baby. Administer oxygen at 8 to 10 liters a minute via face mask to improve fetal oxygenation. Inform and educate the client and their partner about the interventions. Meconium-stained amniotic fluid. Meconium passage in the amniotic fluid during the antepartum period prior to the start of labor is typically not associated with an unfavorable fetal outcome. The fetus has had an episode of loss of sphincter control, allowing meconium to pass into amniotic fluid. Risk factors. There is an increased incidence for meconium in the amniotic fluid after 38 weeks of gestation due to fetal maturity of normal physiological functions. Umbilical cord compression results in fetal hypoxia that stimulates the vagal nerve in mature fetuses. Hypoxia stimulates the vagal nerve, which induces peristalsis of the fetal gastrointestinal GI tract and relaxation of the anal sphincter. Amniotic fluid can vary in color, black to greenish or yellow through meconium-stained amniotic fluid. Though meconium-stained amniotic fluid is often green, consistency can be thin or thick. Criteria for evaluation of meconium-stained amniotic fluid: often present in breech presentation and might not indicate fetal hypoxia. Diagnostic procedures is electronic fetal monitoring. Document color and consistency of stained amniotic fluid. Notify neonatal resuscitation team to be present at birth. Gather equipment needed for neonatal resuscitation. Non-reassuring fetal status is present when the FHR is below 110 or above 160. The FHR shows decreased or no variability. There is a fetal hyperactivity or no fetal activity. Additional manifestations of fetal distress are late decelerations associated with absent or minimal variability, recurrent variables, and prolonged decelerations. Expected findings: non-reassuring FHR pattern with decreased or no variability. Monitor uterine contractions, monitor FHR. The risk factors are fetal anomalies, uterine anomalies, and complications of birth and labor. Monitor vital signs and FHR. Position the client in left lying position. Administer 8 to 10 liters of oxygen. Increase IV fluid rate. Dystocia, which is dysfunctional labor. Dystocia or dysfunctional labor is a difficult or abnormal labor related to the 5 P's of labor: passenger, passageway, powers, position, and psychologic response. Atypical uterine contraction patterns prevent the normal process of labor and its progression. Contractions can be hypotonic, which is weak, inefficient, or completely absent, or hypertonic, which is excessively frequent, uncoordinated, and of strong intensity with inadequate uterine relaxation, with failure to efface and dilate the cervix. Risk factors is short stature, overweight status, age greater than 40, uterine abnormalities, pelvic soft tissue obstruction, fetal macrosomnia, hypertonic or hypotonic uterus, and inappropriate timing of anesthesia or analgesics. Expected findings. Physical assessment findings is lack of progress and dilation, effacement, or fetal descent during labor. A hypotonic uterus is easily indentable even at peak of contractions. A hypertonic uterus cannot be indented even between contractions. Client is ineffective in pushing with no voluntary urge to bear down. Persistent occiput posterior presentation is when the fetal occiput is directed towards the posterior maternal pelvis rather than the anterior pelvis. Persistent occiput posterior position prolongs labor, and the client reports greater back pain as the fetus presses against the maternal sacrum. Diagnostic procedures: ultrasound, amniotomy or stripping of membranes, oxytocin, vacuum-assisted birth, and cesarean birth. Nursing care and dysfunctional labor: assist with the application of fetal scalp electrode and or intrauterine pressure catheter. Assist with amniotomy, encourage client to engage in regular voiding to empty the bladder, encourage ambulation, prepare for possible forceps-assisted or vacuum-assisted birth, continuing monitoring FHR in response to labor. Hypertonic contractions: maintain hydration, promote rest and relaxation, place the client in a lateral position, and provide oxygen by mask. Administer analgesics if prescribed. Oxytocin is used to augment labor and strengthen uterine contractions. Administer if prescribed to augment labor. Oxytocin is not administered for hypertonic contractions. Precipitous labor is defined as labor that lasts 3 hours or less from the onset of contractions to the time of birth. Risk factors: hypertonic uterine dysfunction, non-productive, uncoordinated, painful uterine contractions during labor that are too frequent and too long in duration and do not allow for relaxation of the uterine muscles between contractions. This is considered uterine tetany. Hypertonic contractions do not contribute to the progression of labor, cervical effacement, dilation, and fetal descent. Hypertonic contractions can result in uteroplacental insufficiency, leading to fetal hypoxia. Oxytocin stimulation, administered to augment or induce labor by increasing intensity and duration of contractions. Oxytocin stimulation can lead to hypertonic uterine contractions. Multiparous client can move through the stages of labor more rapidly. Expected findings: low backache, abdominal pressure, palpable uterine contractions, fetal presentation. Assess maternal perineal area for indications of trauma or lacerations. Assess neonate's color and for indications of hypoxia. Patient-centered care: do not leave the client unattended. Encourage the client to maintain a sideline position to optimize uteroplacental perfusion and fetal oxygenation. Prepare for rupturing of membranes upon crowning. Do not attempt to stop birth. Deliver the anterior shoulder located under the maternal symphysis pubis. Nest the posterior shoulder and then allow the rest of the fetal body to slip out. Suction mucus from the fetal mouth and nose with a bulb syringe if newborn is unable to clear the airway or has an airway obstruction. Assess for complications of precipitous labor: cervical, vaginal, or perineal lacerations, amniotic fluid embolism, postpartum hemorrhage, fetal hypoxia due to hypertonic contractions or umbilical cord around the neck. Uterine rupture: complete rupture involves the uterine wall, peritoneal cavity and or broad ligament. Internal bleeding is present. Incomplete rupture occurs with dehiscence at the site of a prior scar, cesarean birth, surgical intervention. Internal bleeding might not be present. This is a rare but life-threatening obstetric injury. Risk factors: congenital uterine abnormality, uterine trauma due to accident or surgery, overdistension of the uterus from a fetus who is large for gestational age, tachysystole of the uterus, forceps-assisted birth, multi-gravity clients. Nursing care: administer IV fluids, administer oxygen, administer blood product transfusions if prescribed. Anaphylactoid syndrome of pregnancy, or amniotic fluid embolism, occurs when there is a rupture in the amniotic sac or maternal uterine veins accompanied by high intrauterine pressure that causes infiltration of the amniotic fluid into the maternal circulation. The amniotic fluid then travels to and obstructs pulmonary vessels and causes respiratory distress and circulatory collapse. It can occur during labor, birth, or within 30 minutes following birth. Meconium-stained amniotic fluid or fluid containing particulate matter that can cause devastating maternal damage because it readily clogs the pulmonary veins completely. Serous coagulation problems such as disseminated intravascular coagulopathy, DIC, can occur. Risk factors: placenta previa or abruption, preeclampsia, eclampsia, oxytocin administration, cesarean birth, labor abduction, and cervical laceration. Expected findings: indications of respiratory distress, restlessness, cyanosis, dyspnea, pulmonary edema, and respiratory arrest. Indications of coagulation failure: bleeding from incisions and vein puncture sites, petechiae and ecmosis, and uterine autonomy. Indications of circulatory collapse: tachycardia, hypotension, shock, and cardiac arrest. Nursing care: administer oxygen via mask 8 to 10 liters a minute. Assist in intubation and mechanical ventilation. Perform cardiopulmonary resuscitation if necessary. Administer IV fluids. Position the client on one side with the pelvis tilted at a 30-degree angle.